Welcome to our discussion about the future of medical cannabis. I'm Libby Znaimer. Cannabis has been legal for medical use in Canada since 2001, and more than 330,000 Canadians are registered medical marijuana patients. But how will that change now that cannabis is becoming legal for recreational use and available through new retail channels? We've gathered a panel of experts to answer these questions and to weigh in on what should be done to make the system work best for patients. Our panelists today are Dr. Daniel Schecter, a family physician, medical cannabis expert, and chief medical officer of the Cannabinoid Medical Clinic; Janet Yale, the president and CEO of the Arthritis Society; Dr. David CASARETT, a palliative care physician and member of the Duke Cancer Institute at Duke University School of Medicine, a health services researcher, and a TEDx speaker on medical cannabis; Moses Znaimer, the president of CARP, a Canadian media innovator and the founder of Zoomer Media; Andre Picard, the health columnist for the Globe and Mail; and Michael Boyven, a clinical pharmacist consultant and leader in medical cannabis education. Welcome. Thanks so much for being with us. Okay, well, recreational marijuana becomes legal on October 17th. That means a lot of people who would have gone through the system for medical cannabis will be medicating themselves. What will the impact of that be, and are medical practitioners prepared to deal with it? So let's start with Dr. Schecter.
Well, thanks for having me. The first thing we have to remember is that people have been medicating themselves for 5,000 years. There's nothing new about that. And what will change is that people will be a lot less shy. There'll be a lot less stigma associated with cannabis so that they will be able to go and talk to their doctor. They will be able to have a conversation that is not impacted by all the stigma that they've been living with for the previous generation or two.
Andre, do you see it the same way?
Yeah, I think the lifting of the stigma is going to be important. People are going to be able to talk openly. And I think we're going to have more serious discussions about the distinctions between recreational and medical marijuana. Because now, let's be honest, some people who have prescriptions, it's because they just want to get the drug for recreational purposes. Once we make that clear, it's available to everyone. I think it'll be used more responsibly and more smartly by consumers and by doctors.
Moses, how do you see that?
I see it as a matter of concern because I think there will be a wave of interest given the ease with which one can now get marijuana. At the same time, I'm here to remind our parishioners, our members of CARP, older Canadians, that generally speaking, most older Canadians are taking a variety of pharmaceutical medicines for a variety of conditions, and they should be mindful of that as they proceed to try marijuana if they haven't already tried marijuana. And that's why our position at CARP has been that we think medical marijuana should be largely dispensed in pharmacies.
Michael?
I would love to see that myself. I think that really the issue here is that we have, come next week, we're going to have access easier from recreational than on medical side. So the people that truly need it may have trouble actually getting it. And I think that's a fundamental issue with the current system. I think also what I'm worried about is that although people may be able to actually talk to physicians more readily, we don't necessarily have the training, or healthcare professionals that have the training to be able to deal with these issues as well.
I was going to bring that up because it's one thing if you feel now free to go to talk to your doctor about what might help you, but your doctor isn't necessarily going to be up on it.
Absolutely, and doctors have a responsibility to themselves, to their patients, and to society as a whole to learn about medical cannabis, to develop knowledge, to develop a vocabulary, to be able to talk about this intelligently with their patients, to be able to talk about the risks and the potential benefits, talk about medication interactions, talk about the difference between medical and recreational, talk about the potential effects on their teenagers, all of these things that we don't learn about in medical school. We're still learning that cannabis is a drug of abuse and we have to discourage it for everyone.
Doctor, it's been a long time where we've known that marijuana really helps with the symptoms and side effects of cancer and cancer treatment. But beyond that, it's a lot newer.
I think that's true, and we were talking about stigma earlier, and I think there are a lot of things that will change and shift that stigma over time, but one of the most powerful things, I think, will be research. I think that stigma will remain until there's a strong body of evidence, and there is some for some conditions, but for many conditions that cannabis is used for frequently, like PTSD, the United States alone, there are well over 1 million people using cannabis for PTSD, and there's no good randomized controlled trials supporting its use. So I think we also need randomized controlled trials outside of cancer diagnoses to understand what it does, how it works, how it interacts with other medications.
Janet, arthritis, that's one of the main indications. I don't know how proven it is, but a lot of people with arthritis use medical cannabis.
Absolutely. One of the things that is really important to know is that there is a lot of undertreatment of chronic pain. And for people with arthritis, their healthcare practitioner may be able to deal with the symptoms of their disease, but tend not to worry so much about the pain. As a consequence, people are living in constant pain if they have a chronic disease like arthritis. And so one of the reasons we've gotten involved in the medical cannabis debate is because over half of the people that use medical cannabis do it for the alleviation of arthritis pain. So we feel that it's really important to help address that stigma and to empower patients not to take no from their physician. When the physician says, well, I don't know and understand that I'm not prepared to authorize it for you. And one of our jobs at the Arthritis Society is to empower people not to take no for an answer and to understand that they have the right to get treatment for their pain as much as for the other symptoms of their disease.
You're nodding.
What's that?
You're nodding your head.
Well, I am in agreement, and with all the experts at this table, I feel a little intimidated, but then I think of myself as a representative of the layman here, and want to reflect the fact that in large measure, older Canadians that we've polled are hugely in support of the idea of cannabis for medical purposes. And that's why, as I said earlier, I want them to be mindful to check with either the doctor or the pharmacist with whom they have a long-standing relationship to make sure that the interactions that they will set off are going to be beneficial to them.
Yeah, I think, Libby, the real point of agreement that everyone agrees on is more research is needed. Consumers want this, but they want to know it's safe. They want to know it's going to work. And but we have to recognize there's been these real legal barriers. It's almost impossible to do research on cannabis in the US, which is the research capital of the world. So there has to be a mixture of, there's a lot of anecdote now, and we have to translate the anecdote into reality. And that's the next step. But I don't think we can just sit back and do nothing while waiting for that. There has to be a mixture of anecdote and real research here.
The other side of that, though, is that I'm hearing claims about everything, marijuana is almost like a miracle cure, the founder of youth. So let's go through what are some of the things that, let's not say are proven, but we have some evidence that it will work for.
Yeah. Well, the best evidence we have around using cannabis in medical practice is for treating chronic pain, specifically chronic neuropathic pain. Secondly, spasticity, especially when it's secondary to multiple sclerosis, but really for any central cord lesion. And lastly, symptoms relating to people who are living with cancer. So things like chemotherapy-induced nausea and vomiting, anxiety, sleep, decreased appetite. These are the things where cannabis can be most beneficial. Everything else is dubious in terms of the claims. And usually there is some element of truth, meaning that there might be some preclinical studies, there might be some anecdotal reports, but we don't have the randomized controlled trials to actually say that, yes, it's good for dementia, or it's good for autism, or it's good for PTSD.
Can I just jump in on that? One of the other areas that is showing a lot of promise is severe epilepsy in children. And Sick Kids Hospital is actually doing a small randomized control trial in that area. But I totally agree that the absence of robust clinical evidence is one of the barriers to physicians feeling comfortable because they don't necessarily know the form and dosage guidelines to deal with that. So we at the Arthritis Society have authorized 2 pieces of research, one on basic research to understand the endocannabinoid system and why it is that the experience you have in your knee triggers pain in your brain, right? Because we really don't necessarily understand those pain pathways. And the other is a clinical trial on fibromyalgia, which is a whole body experience of pain that is a form of arthritis. I should also say that the Canadian government has taken a leadership role in this, and the Canadian Institutes of Health Research, which are the biggest health research funders in Canada, have decided to make a real push on cannabis research on a cross-institute basis, and that's both on the recreational and medical side, and very, very encouraging.
I want to pick up on this confusion or lack of clarity around, first of all, dosage, and second of all, as with any drug, it works differently on different people. So how do you resolve that?
The problem is that it's going to be very, very difficult to do RCTs or randomized controlled trials that compare cannabis versus placebo, because if it's vaporized, if it's smoked, how much do you inhale? How do you take it? With oils, every one of us metabolize it different. Each of these strains could be different in terms of what the responses are. So it's going to be difficult to have these RCTs on a large level of what that looks like. My feeling is that this is not a first-line treatment. This is not what we come in and say, oh, you have pain, you have arthritis. We're going to go directly to this before everything else. This is an option where these people that are not getting optimal management, that we can look at an option that actually helps a large portion of these individual populations.
Mm-hmm. And would you expect that some of the people who are now on medical cannabis are suddenly going to come off of that stream, and what's going to happen? How will that change the market?
Well, I think we know from other jurisdictions like Washington State that there'll be a substantial drop. So we have 330,000 medical cannabis users now. It'll probably fall by half, because the reality is some people just wanted access to the drug for recreational purposes. That's going to be allowed come October 17th. So it's going to eliminate that. Another part of it is people will know their regime, they'll know their dose, and they'll just be able to go to the cannabis store and purchase it. So they won't have to go through. The problem with our system now is it's very, very bureaucratic and tedious. And if you can just go to the store and buy your drug, it'll be a lot simpler. So I think the numbers will drop substantially, but probably the number of medical marijuana users will probably grow overall, I think.
Yeah, so, I think you're absolutely right. We're going to see a precipitous decline in the initial number of medical patients, but over time, as people start using cannabis off the shelf and find that, hey, it's helping for my arthritic pain, or it's helping for sleep or anxiety, they'll be going to their doctors, talking about the alleviation of symptoms that cannabis is providing them, and accessing the legal medicinal route. And there's also going to be some advantages to doing that. There's potential coverage, there's discounts if you're a CART member, I believe.
There are.
There's, you might be able to write it off on your taxes. That's something that people don't realize. And if you're spending $3,000 a year on cannabis, that's a significant tax deduction. So there's a number of reasons why I think the future of medical cannabis is going to look very promising. And we're also going to see different formulations that are going to be developing that are different than just dried cannabis flower or oils.
Well, that's what I was wondering about, that you seem to be under the assumption that these retail outlets selling recreational pot are going to have all the various different strains of CBD, that they're going to carry this. First of all, those things are really expensive.
All cannabis is expensive.
Well,
All medications are expensive.
If I could jump in on that, I mean, the real issue that I think is going on here is there are big disincentives to using medical cannabis in terms of access and affordability both. And that's because there's still that stigma, and we don't really think of it as medicine. And if it's really medicine, then it should be distributed through pharmacy. There should not be HST or excise tax paid on it. So there's not going to be, there's so much worry that if we don't charge tax on the medical stream but do on the recreational stream, then people will use medical cannabis when they don't really need it. I think we have to come to terms with the fact it's medicine, it shouldn't be taxed, and it should be available in pharmacies. And on the affordability side, it should be covered in drug benefit plans. So one of the things we did as part of our initiative in this area was we created, Daniel was one of our advisors in doing that, was we created a package for how to cover it under drug employee benefit plans. And we've made all of those tools and resources available on our website so that in addition to covering it for our own employees as of February 1st of this year, we're trying to make it easy for insurance companies working with employers to start making it much more affordable, because right now people largely pay out of pocket, which if it's medicine shouldn't be the case.
Well, that's right, and there are some big union covers it.
There's a couple big unions that cover it in Ontario and across Canada, and they'll cover it for every condition from what I understand, not just for cancer or for palliation or for epilepsy or for neuropathic pain. They consider it a medication. They trust that physicians will be intelligent enough to assess their patients and prescribe the right medication for the right person at the right time. And we just want people to realize that physicians are smart enough to be able to do that. We're not going to be, we're prescribing cannabis to anyone who walks in the door. That's just not true.
Dr. CASARETT, you mentioned the experience in the States. Now, they have a very different regime. Medical marijuana is legal, but not everywhere. What can we learn from the experience of where it is both recreational and medical are legal in the United States, like Colorado?
Yeah, I think probably the most central lesson is don't do it the way that we've done it. I think that applies to a lot of things in the United States, actually, government included. But I think one of the biggest problems that we have in the US is, as you say, it's illegal at a federal level, but legal in some states, but not others, recreationally and medically, which results in this weird mosaic for patients. It's like saying Tylenol is safe and effective in Halifax, but it's illegal and will put you in jail if you use it in Montreal. It makes no sense, but that's what we do. And some of those implications are it's really tough to run a legitimate business in the United States. It tends to be cash business, which is a problem for a lot of reasons. There's also a paucity of research funding. The National Institutes of Health in the United States doesn't support the good research that they should. And there really aren't good consumer protections. There are all sorts of claims, as you alluded to before, about the benefits of medical cannabis for all sorts of indications. If you Google cannabis and warts, you'll find both case reports and some promises of dispensaries that cannabis is effective. And because it's illegal and ignored at a federal level, there really aren't any global constraints on what cannabis dispensaries can promise. And so they promise the moon, which misleads
I've heard they should be putting it in the water for everybody. That's
And,
good for everything.
And there's also regulatory concerns because there's no federal laws. There's nothing that says cannabis has to be tested. And there's no national standards on testing. So that means that cannabis could be tested 20% THC at one lab, 5% THC at another, because there's no national standards.
Which is why trusted providers become more important, particularly in this initial period. I wanted to make a small point earlier, Libby, that we're all sitting around here assuming everybody has a family doctor. They don't. And that everybody lives in a big metropolitan center with a great deal of stuff available in a variety of locations. Once you get out into rural areas, more sparsely populated areas, it's an entirely different story, isn't it?
Absolutely. If you look at, my mom lives in rural New Brunswick, there is no access. There's no access to anybody. So if you wanted to try it, you thought this would be a potential benefit, you're not going to be able to get it. And so now I think that those people are going to migrate to the recreational space, but my mom's obviously over the age of 65. There's issues in terms of a health side. Could this be a potential problem for her? She's not going to necessarily get the support that she needs. So I really would love to see the medical system thrive in terms of in the age of the recreational space.
So how is the patient experience with medical cannabis different than it would be with just a traditional pharma drug?
Do you want to start? I can pick it up.
Why don't you start? I'll back.
Well, I think the fact of the matter is that for people with arthritis, say you have inflammatory arthritis and you go to your rheumatologist and your rheumatologist prescribes you biologic for the treatment of your arthritis, but you're still living in pain, and the biologic doesn't necessarily address your pain. You go to your rheumatologist and you say, I've heard that their medical cannabis might be an option for me to address my chronic pain. And in many cases, the rheumatologist will not authorize it. So you then have to try and figure out if there is a cannabis clinic in your city, like the clinic system that DANIAL's involved in, and then get yourself to one of those and talk about your symptoms, and you may then get an authorization that you then have to fulfill by mail order. Because mail order is the only legal way to get medical cannabis, and under the new regime will continue to be the only legal way to get medical cannabis unless and until we get it in pharmacies. So that's pretty hard. And then you go back to check 6 months later with your rheumatologist about how your disease is progressing, but your pain treatment is outside the disease management context. And I think that's problematic for patients because of the potential for interactions between your disease management drugs and your pain management, and you want someone to deal with you holistically as a person because it's your whole person that's suffering from the disease.
And you're right, it's hugely problematic that you're not getting your medication from the same people, pharmacists, that you get all your other medications from. Because as a physician, when you prescribe any medication, you have to counsel a patient. You have to warn them about potential side effects, adverse events, what to expect, how to take it, what dose, what quantity, what time. And physicians just don't have that expertise and knowledge to talk about cannabis in those terms. The people who are in best position to talk about that are pharmacists.
And their interactions, I'm thinking we'd talk about older people who might be wanting to use this, and some of the drugs that older people regularly take, sleeping pills, benzodiazepines, I think there's a really big potential for interactions.
So the key concern for me is if you look at people that are over the age of 65, they're more sensitive to the adverse effects from, or side effects from cannabis, first and foremost. So how do they pick the right product? How do they select what they're going to choose? What about drug interactions with this one? There are a few of these that can interact with it. So I think that if anything, as we see more people use this, we're going to need more support, not less. And ideally, if we look at every other country in the world that has a medical cannabis system, it goes through specially trained pharmacies. In every other country except for Canada, we're the only mail order country that ends up having this. And this is a fundamental issue to me.
Wow. So is it just other G7 countries that
These
have
would be
this?
all the countries. So we're looking at Germany, Israel, Colombia is going that way as well. So it's all going to be coming in through pharmacy because like every other region, cannabis is not considered a drug in Canada. It's just considered, whatever it is, it falls in that recreational medical space, the way that the government looks at it now. To me, I want it to be seen, medical cannabis should be viewed as a medication and a medication option to treat a variety of different conditions and to be considered for that, for the right patient at the right time.
Yeah, I think, Libby, that's the key point, is this drug is in this gray zone. It's treated differently from any other drug. Only about 10% of physicians will prescribe it. It's bureaucratic to get it. Patients aren't sure where to get information. So we really need some clarity, especially with legalization. We should be clear that you're going to buy a drug to treat something at a pharmacy like other drugs and not at the corner, at the store, at the cannabis store like you would buy your bottle of rye.
From a 19-year-old.
Yeah.
It probably will go that way, but just to play devil's advocate, I think we will be giving up something if medical cannabis is regimented in that way. I think one of the odd and unexpected advantages to the way that medical cannabis is used in the United States is because it's not provided in that way. Patients can buy from whoever they want in whatever dose and whatever form they want. That may not be safe, it may not be effective, and there's certainly some issues there. But I've realized it does give patients an awful lot of control over their illness. And it's a sense of control that often patients with chronic illnesses have had to give up as they've become older and more frail and given up control over their life, their work, their bodily functions. Being able to take control over at least one aspect of their medical management is really very, very powerfully attractive. And if we can find a way to make that safe, I think we could all win.
Moses?
I wanted to ask the doctor, you then use cannabis regularly in your palliative practice?
The technical answer to that is I can't. I practice in North Carolina, which is one of those states where medical cannabis is not legal. However, I would say probably 10 to 20% of my patients do use it. I can't officially recommend it, but we certainly talk about it. I wouldn't be doing my job as a physician if I didn't ask about a drug that I thought my patients were using.
And you see it being effective?
Would echo the comments
Absolutely.
previously that there are many conditions like loss of appetite, insomnia, pain, particularly neuropathic pain, where I think medical cannabis is very effective.
So what is it that is required to take mountains of anecdotal evidence and accept that there's a reality there?
If I could take a swing at that, I think the answer is different depending on who you are. If you are a patient with chronic pain for whom Tylenol works well, then I would probably want a lot of randomized controlled trial evidence before I use medical cannabis. If I'm the parent of a child with epilepsy who has been through 6 or 7 medications, is currently taking 18 pills a day, my level of evidence that I would look for would be substantially lower. So how much evidence you require is not a function, I think, of whether patients are naive or gullible. It's really a function of what they have on the table, what their other options are. And I think patients all make that decision often very intelligently, but differently.
We've been talking about some gaps in the system. Where do you think it's doing a good job?
Well, I mean, I think the fact that the federal government, under the leadership with the task force, decided to keep the medical regime in place post-legalization of recreational marijuana was actually a brave recommendation on the part of the task force, because many of the healthcare practitioners, including the Canadian Medical Association, made the argument that once marijuana is legalized, you don't need a medical regime. And so for
Just
me,
washing their hands, basically.
well, I think they felt that the medical practitioners don't want to be the gatekeepers in terms of access to cannabis for all the reasons we've discussed, in terms of not knowing it, not understanding it, not knowing, having good clinical guidelines. So they wanted it eliminated. And I, as a participant in many of those task force conversations, I think it was incredibly great that the government withstood that pressure from some of the medical practitioners. And in fact, if I can tell one tale, we were concerned that medical professional pressure was going to outweigh the voice of patients. And the task force asked a number of the patient groups to convene a special session, anecdotal, but powerful. And all of the task force members came to a special session just with patients, people with MS, people with cancer, people with arthritis, a whole bunch of parents of children with very, very severe epilepsy, and they just spent 3 hours telling the stories of how medical cannabis had saved their lives and changed their lives for the better. And I think understanding that was really powerful, and it was what persuaded the task force, one of the factors that persuaded them to keep the medical regime intact. And the legislation that is coming into force on October 17th is testament to that. So I think that was the most powerful thing the Canadian government could do, was to keep it in place and say, we're not going to change it for 5 years. And in that time, we know there's going to be a lot more research being done that will create the evidentiary base that we're all wanting to see in place, and give us time to address the other issues like pharmacy distribution, like taxation. So I'm one of these optimists that thinks that 5 years from now, we'll look back on this and say, what were we so worried about?
Is that a good timeline? Is it too long to figure out?
I think it's reasonable. You know, we've been doing this, can't forget, we've had medical cannabis in Canada for 20 years now. That's a good thing. And I think, as Janet said, it's very smart to say, let's give it 5 years, let's let this play out and see how it goes, rather than just throwing out the baby with the bathwater. I think there's a real temptation to do that. And I think 5 years may not be enough, but it can be extended. I think we'll see a very different medical marijuana regime in 5 years, but we're going to do it slowly rather than dramatically.
And if we do the research properly, we're also going to see a lot of very different products on the market. I think physicians in 5 or 10 or 15 years who are interested in cannabinoid-based medicine are going to look back and say, why were we prescribing grams of a dried plant material? They're going to be having sprays and pills and tabs and oral dissolving tablets and patches, all sorts of
Capsules,
things.
things that can be measured,
That's
things
right.
that you can titrate,
And
things that
they're
are
going to be a lot
consistent.
more precise, and it's going to look and feel much more like a medication, much more like what our patients are used to and what physicians are used to actually prescribing.
100 years ago, we used to treat rickets with cod liver oil, which seems crazy now, but that was one first step that led people to understand the process.
We
of
also
bone
used to treat
formation.
rickets with cannabis oil 100 years ago.
I did not know that. Was there ever a randomized control trial compared to
No, one thing we should remember though is that when, cannabis was used widely before 1937 in the West. And cannabis was made illegal for a number of different reasons in Western cultures. For political, for social, for economic, for racial. And when cannabis was made illegal in the United States in 1937, the American Medical Association was categorically against making cannabis illegal because they knew that it had medicinal benefits and properties. And it's almost like we're coming full circle now. Now the American Medical Association, the Canadian Medical Associations are against cannabis, but patients want it and patients want to use it. And government is saying, hey, maybe this is a good idea.
Let's blue sky things a little. So do you have a sense of how you would like the system to evolve in the 5-year period?
For me, I would love to see more education for healthcare providers, more education for patients. So they're not looking and saying, I should be taking it for everything, such as I have a toe fungus, I'm going to end up using cannabis for it. I think that we need that gap that's there, and I think that what it comes down to is specifics. I think one of the biggest criticisms now is what product do we pick for what patient at what time? And if we have more information in the next 5 years, we'll say this is a great starting point for that specific condition for this patient. That is where the future is going to be, hopefully, in terms of medical cannabis.
Any other ideas?
I think absolutely we need pharmacist dispensing. That is going to legitimize it in the eyes of patients, in the eyes of physicians, and make it much more accessible. The other thing that I would like to see changed is not to allow patients the ability to grow an infinite amount of cannabis for personal use, which will very likely be getting diverted into the black or the gray market. I think that is a big, big disservice to the medical patient.
I think one other way that Canada could really be at the forefront of this field is to encourage research on patients who are using it. 300,000 patients who are using it in Canada legally now. We have a lot to learn, not in the same way that we would learn from a randomized control trial, but rigorous registries that allow patients to report their own experiences, good, bad, in between. Just based on that alone, Canada could be at the forefront of descriptive observations.
And we already have a number of those going on. In Quebec, we have the Quebec Cannabis Registry, where 3,000 patients were enrolled and are being monitored for a period of 2 years. We have other registries going on in other parts of the country. We have apps that have been developed that people can monitor their own progress. And that is being reported, and information is being mined from those data apps.
Yeah, I think what consumers really want is clarity. They want to know what product for what condition, at what dose, and how much. I think that's where we're missing. It's still kind of a little messy out there, and if they get that clarity, I think that will make it much more legitimate. It'll take away a lot of the stigma. A lot of the public still think that medical marijuana is, I'm going to give you a bong and you're going to go home and smoke it. And it's not that. It's starting to be pills and drops, and it'll soon be edibles. And so I think when that clarity is there, what you use it for the right thing at the right time, like other medication, a lot of this stigma will fall away.
And then finally, the affordability question. I mean, we've talked about research, we've talked about access. I think the affordability issue is a big one because to the extent that it is out of your pocket, that you have to pay for it and not covered by benefit plans, to the extent that there is both an HST and excise tax, which doesn't apply to other medicines. That's part of the stigma, but it's also really affects the affordability of it. And I think what we'll see over time is that even if we let the price come down, we don't apply tax like we do to other medicines, let come under drug benefit plans, we're not going to see people using the medical stream because they want recreational marijuana. We have to trust that this is going to be used appropriately, as Daniel was describing, and really make it affordable as part of an overall treatment plan.
I have to say, on my radio show, I've done many pharma segments, many segments on medical cannabis, and some of the most heartbreaking calls that I've fielded are from people who say, I have chronic pain, I am on opioids, I want to get off opioids, but I can't because I can't afford the medical cannabis, and it's not covered, usually under government programs for older people.
There's this recent experience with the veterans in Ottawa who were using cannabis for PTSD, and began with 3 grams a day, but steadily the amounts increased, and eventually the Veterans Affairs people became suspicious because the 3 grams a day had gone up to 10 grams a day, and there was this sudden fear, this suspicion that the people, in addition to helping themselves, were possibly enjoying themselves. And so government had to put an end to that. And I wanted to ask you in particular, because I've always suspected that euphoria is in some ways part of a cure. I mean, if we're talking in particular about those veterans and the personal problems that they experience and the various maladies and hurts that we're trying to address. Or if you're in intractable pain from cancer or whatever, and there's something that can take your mind off that, even for a half hour or an hour, why would we begrudge that? Why?
So you're absolutely right. And when I talk to patients, I always make a point of asking, what exactly does cannabis do for you? Why are you coming back, and why do you want to use it again? And 99 times out of 100, they tell us it does 2 things. On the one hand, it reduces their pain by about 30%, maybe 3 points on a 10-point scale. But the other thing that they say it does is that it gets their mind off their pain, and that it gets their mind off their pain enough so that they can sit down and focus on what matters to them, on having a conversation with their family, on reading a book, on doing work, on going for a walk, without being constantly reminded that they have this horrible agony that is this pain. And cannabis, like you said, just gives them a little bit of relief. And it's not because they're high. It's because cannabis works in a different manner.
No,
and that's what people don't understand.
They're returned to normal in a way.
Exactly.
They're not high, they're just getting back to normal.
Yes.
And we have this notion that THC is recreational and CBD is medicinal, but it's not that black and white, is it?
Not at all, because many, many people are finding tremendous benefit with THC. That is the main driver that helps with spasticity, with pain, with nausea and vomiting. And CBD has a role. It's great as an anti-inflammatory. It helps with analgesia. It's great for epilepsy. But they're both useful in medicine. You can't have one without the other.
You know, what you said was really important because you talked about a follow-up visit. And to my mind, what might be one of the problems now is that you find a doctor or some of the licensed producers have doctors on staff, they sign you up, and that's it. You either reorder or don't reorder. So there's that whole issue of follow-up, whether it's with a doctor or with a pharmacist.
I think the issue too is that if the family physician is fundamentally against it, but the patient wants to try it and goes to a different source and doesn't go to a clinic like Daniel's where they're being referred, they're on their own. There's nobody necessarily there to help them. So these are the people that are falling through the cracks. They can run into issues. They need support. They have issues there. So the more help that they can end up getting, the better it's going to be for those patients and their outcomes.
Yeah, and I'm not sure people really understand how varied cannabis can be, an infinite variety of different strains with different combinations of THC and CBD. There is this sort of sense that it's all the same, it's all plunk, but over time, as things become more refined and a variety of mass and craft growers emerge, I think the medical profession will learn that this is good for that, and this is good for that.
But right now, at least in the United States, it's overwhelming, the choices that patients face. And often, if they don't have a physician who's willing to talk them through the options, they're at the mercy of a dispensary bud tender who has limited knowledge often and equally often incentive to upsell. to try to sell the most expensive product on the shelves.
That Afghani bull rider is really, really good for cancer.
Well, and that's why these, from a patient perspective, we really support that it be part of the medical system. And what we understand from the US is where the medical and recreational are sold side by side in a store setting is not ideal, particularly if there are price differences between the two. So I think we really believe, picking up on what everybody else has said, that it really has to be part of the medication regime that a person, it's not that we're advocating that everybody should use medical cannabis, it's that if you're living with devastating chronic pain, there have to be non-addictive options because it's not an acute pain that's going to go away in post-surgery use of certain opioids or whatever. We really think that chronic pain, which is very prevalent in people with arthritis, we need to take that seriously and need non-addictive options for people.
Libby, I forgot one of the punchlines in my story about the veterans, which was as their use of medical marijuana went up, their use of opioids went down, almost commensurately. The amount of money spent on extra marijuana was offset by the amount that was saved on opioids.
And that's what we see in studies across the world. In Israel, where they had an elderly population of 3,000 people using medical cannabis, we saw 6 months later that their average number of prescriptions were decreased significantly, their quality of life improved significantly, and they were happier.
Would you consider them the leaders in the world in medical cannabis, Israel?
I would say Canada is the leader, but if we don't continue to focus on research and focus on medicine, we have a chance of going by the wayside. And all of the tremendous advancements that we've made over the past 5 years are going to go up in smoke.
Or oil.
One other thing that I would love to see, over the next 5 years before the next review is to have some good pharmacoeconomic data around the use of cannabis, exactly like you're saying, and seeing whether people who are authorized medical cannabis, the amount of dollars that it costs the medical system is decreased, whether it be in medication or physician visits or emergency room visits. This is data that would be so incredibly valuable.
I didn't think of all those other things around that. I guess that if you're sort of more at peace, not in pain.
Yeah, if you're not in pain, you're not going to see your doctor, you're not going to the emerge, you're
Able to work.
able to work.
And just substituting cannabis for other drugs that are expensive.
Yeah.
Yeah.
To me, how do you put a price on function? Like really in terms of the quality of life of these people they experience. You see these people in chronic pain, many of them don't have adequate treatments. Are falling through the wayside. They're having all this pain constantly all the time. Why are we going to discount one treatment of many options that we have for our patients? So find something that actually works.
It's really, although that is in theory, having that sort of study is really important. It's always hard when you're trying to make these arguments politically to say that we need to invest today to save money over time. And yet we know that people who are living in chronic pain aren't as productive, aren't as able to work. If they take it, the way arthritis works is often there are flares that cause people to need to take a break from work. Well, if you know that you're not going to have good pain management, you may stay off work that much longer because you're afraid that if you come back and it's not under control, you won't be a very effective worker, and there could be repercussions for you in terms of not being seen as a good and productive employee. So this cycle that happens with people with these chronic conditions that have episodes of better and worse is really destructive for people, and helping them find all of the support they need, both pharmacological treatments like medical cannabis, but also other treatments like physio. And we have to think about this in the context of the larger healthcare system and what it takes for a person to be able to be as productive as they can. I don't want people to think that we at the Arthritis Society think medical cannabis is the solution to chronic pain and everything is great as long as people use medical cannabis. That's not the point. We just really want to make sure that there is, that it's an effective alternative that is considered responsibly by pharmacy, by healthcare practitioners as a way to improve quality of life for people who have these chronic conditions.
Okay, so what I've been getting here is that everybody at the table thinks that the federal government is taking the right approach, but are they putting enough resources behind this?
Medical marijuana at this point is not top of their mind. I think that's what all of us have been saying, and it's time they came back to the subject and dealt with it a little more carefully.
Yeah, and showing a commitment to research, to doing the right studies to look at whether it makes sense to have broad-based coverage, to push research even further, to put a lot of money into this.
That broad-based coverage. So, for instance, if you're talking about coverage for people over 65, say, that is something that the provinces are in charge of. So how much does it complicate things that the federal government does some things, the provinces do others, Andre?
Well, that's the story of Canada. So
Yes.
we deal with that every day. I don't think that's unnecessarily complicated, but I think the issue is we're getting into this new regime where we have legal recreational cannabis. There's going to be an influx of billions of dollars in taxes. How are we going to spend that responsibly? Some of it is going to be to educate and prevent harm from recreational cannabis, but another part of it has to be to invest in research into medicinal cannabis and learning
I
as
haven't
best we
heard
can.
plans to do that from the recreational money.
Well, there is some money, CAIHR, and
Well,
to
yeah,
their
but
credit,
that's-
the companies, the big companies that are doing very well on the stock market these days are making some big investments in research as well, to their credit.
And there's two different kinds of research. So CIHR isn't going to do randomized control trials, right? That their research tends to be basic research, understanding how cannabis works in the system, thinking about, and many of the issues that that would be addressed through CIHR research are things that are common to recreational and medical, right? How does the system work in your body? So the same research that we need to do to understand its influence on young people, safe driving, a lot of the basic research questions that CIHR will undertake as part of their commitment to more investment in research are things that are relevant both for the recreational and medical market, and I think that's great. The real issue is, are there incentives for pharmaceutical companies or licensed producers to do the kind of studies that they can then turn those products into pills or things that can get an actual drug approval from Health Canada that could then be prescribed the way other medications are done. And I think I think now with the medical regime preserved, I certainly hear that there's lots of investments being made in clinical trials by various companies, because the ones that can figure out how to get those pills approved by Health Canada are the ones who are going to presumably make a lot of money from doing it. So I think there are big financial incentives now for that kind of research to be taking place. So,
What else? What else do we have to watch out for that will be imminent when this thing happens? Legalization.
Well, I could put my 2 cents in from south of the border. I think anytime there is anything that dramatically increases in usage, you have to be concerned about public health effects. And when you see more people using any substance in different ways, I think there are probably going to be unanticipated, unrecognized, underappreciated health consequences. I think there's a pretty good consensus that there is the potential for addiction, for instance, with cannabis. Uncommon, certainly not a sure thing, probably not really relevant to medical cannabis users, but it is relevant to recreational cannabis users. Probably no more than 1 in 10 long-term users at most. And certainly addiction to cannabis isn't as significant as addiction to, say, opioids, but it's still there. And so one thing I wish we had been better at doing in the United States is to begin to take a public health approach to monitor for those sorts of signals. So if we start getting into trouble, as we did in the United States with the opioid epidemic, we recognize it before it gets to be an issue. I'm not trying to be alarmist. I really don't see that happening with cannabis, but it's the dangers you don't pay attention to that you really have to worry about.
I think we have to worry about what you alluded to earlier, that this is perceived as this miracle drug that can cure everything, and everybody starts medicating for everything under the sun by going to the cannabis store and buying products. So I think we have to be careful to remind people that every drug that has a benefit has side effects and it has a downside. So I think that education component is equally important for recreational and for medicinal. The government is talking a lot about educating young people about using cannabis. I think we have to educate older people about using cannabis. You know, it's not our cannabis from the 1970s with 5% THC. It's 15% now, recreationally, and then medicinally. People really need to be informed how drug interactions, what works for what, and there is a really big education component to be done there.
One of the things we're getting calls about is people who have used medical cannabis in their condos. The condo boards are now starting in anticipation of recreational, right? Whether or not it's going to the arrival of recreational cannabis or marijuana is going to adversely impact medical users using medical cannabis in their homes.
Well, that's a whole other
issue.
can of worms.
We're also seeing that at long-term care nursing homes. What are you going to do when somebody comes in? There are going to be people that are going to be recreational users that are going to come into a long-term care facility, or medical users. Right now, without having pharmacy involvement with this one, we can't even touch the product. So all the distribution system in a nursing home is completely different. Hospital, it's creating chaos. Who stores it? Where does it go? How do you do with this? We don't know. And so all these individual policies, so here in Ontario, policies are coming into place, but we don't know what that's going to look like 3, 5, or even 6 months down the road, really, at this point.
Wow. It's time to wrap things up. I'd like to go around the table, starting to my left. Just give us a little bit of a final thought, everybody.
Well, I think from the patient community perspective, we're delighted that the medical regime is going to stay in place with the arrival of recreational marijuana being legal on October 17th. And we're looking forward to continuing on behalf of patients pushing for greater access and improved affordability.
Libby, the members of CARP, people we call Zoomers, Boomers, we practically invented marijuana, right? And that means many of us are familiar with it and know that you can have a puff or two and not wake up in the gutter. Which means that many of our members, in fact, the vast majority of them, are for the idea of medical marijuana. And all we have to say is get what you need, but be mindful of everything else that you're taking and make sure you get the best advice as to which strains to use for what problems, and be careful with the interactions with everything else that you're taking. Most Canadians over 65 are taking something on the order of 4 or 5 pharmaceuticals at the same time. That's our message.
From a pharmacist standpoint, I would love to see this come into pharmacy. I think that it legitimizes it and it reduces the stigma associated with this right from the get-go. If people can do this like every other medication, it's just seen as another medication, just another treatment. So it's not as this recreational, or the 75 who's using it for pain, saying, oh, they're just using it recreationally. It's removing that stigma, having pharmacists involved, and then a big push for education, both for patients, government, and healthcare providers to ensure that everybody's getting the right information to their patients at one time or another.
Mm-hmm. Well, from a physician's perspective, who's been working in the medical cannabis world for the past 5 years heavily, a few thoughts. One is that I want to recognize that a lot of my colleagues are not comfortable with the idea of medical cannabis, but I would really want to encourage them to learn about cannabis, whether it be medical or recreational, so that they can at least have an informed and intelligent conversation with all of their patients, those who are using it, those who are using it medicinally, and those who are using it recreationally. And I also want to remind people that the world is not going to fall apart. The sky is not going to fall come October 17th. Cannabis is the most widely used illegal drug across Canada and across the world. And if anything, we are going to have more regulations, more education, and the conversation will be a lot more intelligent come October 17th than what happened beforehand.
And I look forward to the day where we don't have to do roundtables like this because cannabis is just one of many drugs that we have in our armory, and it can be used. It's a series of drugs with specific uses, and it's paid for like others, and we don't have to give it this special status and be all stigmatized about it.
That's a good thought.
Although I really have enjoyed this panel, so I'd be more than happy to do it again.
We'll find another drug to talk about.
I think my parting comments would be that I think this is a really exciting space right now. And I think a lot of what's going on in the medical cannabis world points us in directions that more mainstream healthcare could learn from, whether that's giving patients more control over their own treatment and illness, to learning from patients' experiences, allowing patients to share their experience with others, apps that let patients report their experience, to learn from them. I think a lot of what's going on in this space is stuff that the mainstream medical establishment really could learn a lot from. And so I think both because of the patients we're taking care of, often with multiple chronic serious illnesses, and the sorts of innovation that's going on, I think we have the potential to lead not just in terms of cannabis and research, but in terms of healthcare more broadly.
Okay, well, thank you all. It's really been a fascinating conversation. And if you're considering or currently using cannabis for medical reasons, it's important to do it in the context of your whole health and wellness plan. Even once recreational cannabis is legally available, patients should still have access to a medical cannabis framework that puts their needs first. So speak to your doctor or pharmacist about your cannabis questions. Your health matters.